Hello, can you hear me? Oh, good. Hi. Okay, I'm going to go ahead and start. Welcome to the third Patient Empowerment Summit and second Gastric Cancer Advocacy Day. I'm Aki Smith, caregiver, patient advocate, and founder of Hope for Stomach Cancer. It is truly an honor to welcome you all, patients, survivors, caregivers, healthcare professionals, and advocates, both in person and virtually. This year, our theme is Amplify Your Voice, Shape the Future. Every one of you here today has a voice that matters. Your experiences, your questions, your advocacy, they shape the future of stomach cancer care and research. We begin today with new directions in gastric cancer prevention and recurrence monitoring, followed by an essential conversations on avoiding financial toxicity, because no one should have to choose between their health and financial stability. When my father was diagnosed with advanced stomach cancer, the path forward felt uncertain. But today, thanks to advancements in biomarkers, clinical trials, and targeted treatments, we have more options, more hope. Yet, for many, the journey remains isolating. That's why we're here. Together, we are changing this landscape. A special thank you to our partners in industry and research for their commitment to rare cancers like ours. Your support fuels progress. Beyond the presentations, I encourage you to engage, visit our wellness room, share your story, and take time for yourself because this summit is for you. Now, before we introduce our incredible speakers, let's take a moment to watch this video.
You have to be aggressive and advocate for yourself hard.
Pray a lot for strength because this is going to take every ounce of strength, mentally, physically, emotionally, that you have.
Don't give up because there will be doctors that are very, negative in their prognosis and their outlook.
Don't take that, comment from whoever and think that it's the end.
I decided to switch oncologist. I said, I need an oncologist who's going to fight for me.
So once you get through that anger, do what I did, find a reason to live.
I mentor other cancer patients to help people that are kind of new to this because it's so overwhelming and so scary.
I'm so thankful for the support groups that I've joined that have educated me, and I've learned through them a lot.
Good to talk to people that know what you're going through and know how you're feeling, to have that support. That's just been wonderful.
Lean on friends and relatives. It's not being weak, it's actually a sign of strength by doing that.
Every chance I get, I talk about it. Stomach cancer, genetic testing, funding for stomach cancer research.
My hope is that we can get to a place where there's some sort of screening for this. The doctor mentioned, it's not part of our guidelines to do annual surveillance if they've had H. pylori. Why not?
My hope is that they continue to expand on this immunotherapy. It certainly seemed to work for me.
The hope is that it doesn't really become like a death sentence, right, for people that once they get diagnosed, even though it's scary.
Man, I just tell them to stay strong and fight this, because with today's medicines, there's a lot of good stuff happening nowadays for cancer patients right now.
Okay, and now to introduce our first speakers, I'd like to welcome our founding board member, Irasema Chavez.
Hi, my name is Irasema Chavez, Irasema Partida Chavez, and I am a stomach cancer survivor. I was diagnosed in 2015 with stage 2B stomach cancer. I had a partial gastrectomy initially. I had a recurrence in 2016 and had a total gastrectomy. And I'm here. I'm here, right, because we know early detection saves lives. So I just wanted to introduce myself and let you all know how grateful I am for taking time out of your lives to join us and build this beautiful community and support that we all need from each other. Before I begin, I just would like to thank all the sponsors for this year's summit. The Wi-Fi information for this year's program is on the screen, so maybe take a quick picture of it. And with that, I would like to present our first speaker of the evening. It is Dr. Andrew Chan. Dr. Chan is a gastroenterologist at the Daniel K. Podolsky Professor of Medicine at Harvard Medical School, Professor of Immunology and Infectious Disease at Harvard T.H. Chan Public School of Health, Chief of the Clinical and Translational Epidemiology Unit at Massachusetts General Hospital, and Director of Epidemiology at the MGH Cancer Center. Through work spanning population epidemiology to clinical trials, Dr. Chan's research focuses on prevention and treatment of gastrointestinal cancers. Please welcome Dr. Chan.
Well, thank you very much, Irasema, for that very kind introduction, and it's really an honor to be here at this summit. It's really an inspiring opportunity for me to be able to meet many of you and to really help us, motivate us to really continue the research that we are striving to do, which is to really have an impact on patients with gastric cancer and their families. So I'm a gastroenterologist, and as many of you know, one of the main tasks that we have before us as gastroenterologists is cancer prevention and screening. And we know cancer prevention and screening for gastrointestinal cancers is a really important component of making sure that we have an impact on a very devastating set of cancers. So I've been fortunate to be able to be in the clinic and to be able to make a difference in terms of prevention. But I also have had an opportunity to hopefully make a dent on this problem through research. And so what I'd like to do today is to give you a snapshot of the kind of research that we're doing in gastric cancer prevention and early detection, and what sort of implications that might have for the future so we can continue to make a difference. So I think all of you are aware of these survival curves, and they're really disturbing. I think we all know that most cases of gastric cancer are diagnosed at later stages, particularly stage 3 and 4. And the survival in stage 3 and 4 disease is poor. And after surgery, we can see that many patients, unfortunately, are succumbing to their disease within 3 or 4 years. But the hope is that we can actually get more patients up into this area, which is where survival is actually quite good. So if we can get more patients into being diagnosed at stage 1 or even stage 2, we can markedly shift the curve and really improve overall survival from this disease. And that's really the reason for why we do what we do in gastric cancer prevention research. So how do we do that? Well, how do we think about detecting gastric cancer early? So one of the main things that we really need to focus on when we ask this question is, what do we know about the natural history of the disease? How does the disease start? And how does it eventually lead to the development of a cancer? Well, what I think we should all be aware of is that it's a stepwise process in most cases. You have normal stomach lining or normal gastric mucosa that over time can develop into gastric cancer through a series of different steps that are well defined and well known through the literature. We know that most cases of gastric cancer are arising in the setting of a condition known as gastritis, where there's inflammation of the stomach. And over time, that inflammation of the stomach can lead to a condition known as atrophic gastritis, where the stomach lining becomes almost sickly and less healthy. And that over time can lead to the development of what we call intestinal metaplasia, where there's actually specific changes in the cells of the lining of the stomach that are precancerous. This intestinal metaplasia over time can develop into something called dysplasia, where there's actually changes in the cells that actually begin to mimic cancer. And sometimes you may even develop what are called adenomas or polyps. And then this finally leads to the situation where intestinal type gastric cancer can be clinically diagnosed. So where do we have the opportunity to intervene? Well, primarily we want to try to intervene really at this early stage if we can. So if we, for example, diagnose people with gastritis, for example, H. pylori gastritis, that's where we give people antibiotics to try to treat that and prevent the gastritis from progressing into more serious conditions. But there's also an opportunity to really prevent the disease by diagnosing people at this stage, in the precancerous stage, where you can potentially screen people and identify areas of the stomach which have developed intestinal metaplasia, or identify areas of the stomach which have developed polyps or adenomas. So this sort of precancer stage is the stage where there is the opportunity to really interrupt this disease process. Unfortunately, though, there's another major type of gastric cancer where screening and prevention is more challenging, and that's the kind of gastric cancer we call diffuse type gastric cancer. And diffuse type gastric cancer is much more difficult to detect. It's difficult to see on endoscopy. And also, we're not sure why people, whether these diffuse type gastric cancers actually go through these same steps. And in many cases, you might have normal gastric mucosa and then diffuse type gastric cancer, and it may not have gone through these various stages. So this is where there's a real clinical challenge in being able to interrupt the disease process because we don't have very clear precancerous steps to really intervene on. The primary causes of diffuse type gastric cancer appear to be genetic. So many of you are familiar, for example, with hereditary forms of gastric cancer known as hereditary diffuse gastric type cancer. And that's oftentimes due to a genetic mutation in something called the CDH1 gene. But there are also some non-hereditary causes that could lead to diffuse type gastric cancer. So our understanding of these two major types of gastric cancer is really what's leading us to really focus on this as maybe two different diseases and two different diseases that require two different approaches for screening and prevention. And at this point, again, what we're motivated to do is to try to shift clinical practice. The vast majority of patients in the United States that are diagnosed with gastric cancer are diagnosed at the stage where they already have gastric cancer and not at precancerous stages. And we really need to try to shift clinical practice such that we can develop newer techniques and newer methods to diagnose people in the precancerous stage or earlier at-risk stage. And that's where we've been really focused on two major areas of prevention. One is to use blood-based biomarkers, and the other is to think about improving our ability to image the stomach or improving our ability to do endoscopy in a way that allows us to detect lesions with more sensitivity. And in so doing, you can really shift clinical practice over and really lead to a format of early detection and improved interception in clinical practice that will really make a difference for our patients. So that's where I've really been fortunate to be able to lead research in this area through the first of its kind Stand Up to Cancer gastric cancer interception research team. So as many of you know, and many of you will hear about over the coming days, gastric cancer research is woefully underfunded. It's really a travesty in terms of the amount of money we spend on gastric cancer research. And there's very, very little attention paid to it in the research community because there has been so little funding available. But in 2020, Stand Up to Cancer came out with an initiative to really try to jumpstart the gastric cancer prevention field by introducing a request for proposals to develop multidisciplinary teams that can address gastric cancer in a novel way. And so I was fortunate to lead a team that was funded by Stand Up to Cancer that's been based on a partnership between our hospital at Mass General, Columbia University with my co-leader, Sandra Riam, who you'll meet, I believe, on Sunday, and also Marty Taylor, who you'll meet, I think, on Monday. So we've been fortunate to also have partners at Samsung Medical Center, City of Hope, Dr. Yang Hee Woo, who many of you know, who will be here as well, and Dr. Jeremy Davis at the NCI and now University of Maryland. And really the center of our team, and I think the real motivator for our group has been Aki. So as part of our team, we really felt that it was important to have patient voices and patient advocates to be able to really inform the research that we do and understand what the priorities are for patients, and to really keep us on task. And so Aki has been a terrific member of our team, and us being able to partner with her has been incredibly important for advancing our science. So with that, I just want to give you a brief outline of the kinds of things we're focused on. So again, we're focused on trying to detect gastric cancer early. So if you look at this schematic and you see the stomach here, we believe that gastric cancer cells that are in the stomach can be detected at an earlier stage, for example, at the precancer stage. And we have two areas of potential focus. One is blood-based biomarkers, where if we can potentially detect things in the bloodstream that reflect what's going on in the stomach, that might be an opportunity for early detection. And I'll cover two areas of research in our team. One is to investigate the ability of something called the line 1 ORF1P protein as an early detection marker, and also the other is to potentially detect tumor cells in the bloodstream early. And these are both promising techniques that we've developed through our work. There's many different blood-based biomarkers, just to sort of cover the landscape. Among the sort of blood-based biomarkers you may have heard of are various markers that are based on detecting fragments of DNA in the blood, as well as, for example, this line 1 ORF1P work that I'll talk about briefly. So line 1 ORF1P will be covered in much more detail by Dr. Taylor's talk, because he's been the person that's really spearheaded this work at Brown University, but just a brief look at it. Line 1 is basically something called a retrotransposon. It's like a viral-like particle that actually inserts into various parts of our genetic code or our DNA. And in most normal tissue, that line 1 is repressed, meaning it's not expressed, it shouldn't be expressed. But for whatever reason, through some processes that we have yet to understand, in the setting of cancer, like gastric cancer, this line 1 protein can be de-repressed, meaning that sort of silencing of line 1 is turned off, so you actually have expression of line 1 retrotransposons in the DNA. And why is that bad? Well, if you have expression of the line 1 protein, then you can, of the line 1 transposon, that leads to the synthesis of a protein known as ORF2. And that ORF2 protein is actually what's detectable in the blood. And so when this line 1 RNA gets transcribed into the cell and into the bloodstream, it can then enter the cell and lead to a lot of additional damage to the cell that can lead to cancer. And so we've been focused on research that's really been trying to interrupt some of these biological pathways that lead to cancer, but also try to determine if we can use the protein that line 1 makes as an early detection biomarker. And it's really been promising work. And so again, Dr. Taylor will go into this in more detail, but we see in a variety of cancers that this line 1 retrotransposon expression is a part of the cancer process. And there's also a lot of this protein that can be detected in various tissues and not in normal cells. And in particular, in gastric cancer, you can see that these proteins are detected in gastric cancer, but not in normal tissue. So this represents, again, a very promising potential biomarker for early detection. And we've started to do some really sort of initial pilot studies which show that it's very highly expressed in patients with gastric cancer compared to patients that don't have gastric cancer. And it's also very much expressed in the tissue. And so we're now starting to embark on clinical studies where we're taking blood from patients at risk for gastric cancer and patients that have developed early stage gastric cancer in particular to see if we can understand better how this protein can be modified to be an early detection test. And we can potentially use this for our patients, in particular patients that might have very difficult to detect tumors, for example, patients with the diffuse type of gastric cancer that I mentioned. And so we've found, for example, that in a small study we did of just 10 healthy people, and 10 patients with gastroesophageal cancer, there is marked elevation of the line 1 protein in the patients with cancer in just a very small amount of blood. So we're continuing to optimize this into a blood assay that we can do in larger numbers of patients, and hopefully we'll have a better sense of whether this would be something we can ramp up into the clinic. It's also a potential early marker of response, and so I think one of the challenges in gastric cancer is after surgery. If you want to monitor people for response, it's a challenge. There's not a lot of things that we can do other than, for example, endoscopy or scans, and those are not always the most sensitive way to detect recurrence. But there is some promise that we can use these blood-based biomarkers as an early marker of response in some of our clinical trials. And so this was a clinical trial that was conducted of patients who were getting systemic therapy for gastroesophageal cancer, and you can see that it actually, whether you had this particular protein or not, predicted whether you would respond to chemotherapy. So people that had high levels of the ORF1p protein were the ones that didn't respond as well, and seen here in the red, whereas people with lower levels of the ORF1p protein did respond pretty well. So the ORF1p protein could be a marker of how well someone responds to chemotherapy, which is very important for our patients. How about the other types of blood-based biomarkers? So one area of interest also for us has been in circulating tumor cells, and this has been very interesting work as well that's been led here at Mass General, where we actually have a specific process by which we can take a patient's blood and actually sort their cells and actually use antibodies and magnets to actually sort tumor cells out from red blood cells. So just to take you back again to the figure, you can see, for example, here that these tumor cells are shunted this way, and these are the normal red blood cells. So by sensitively detecting these circulating tumor cells, we could actually determine whether someone has a cancer in their stomach without necessarily doing an endoscopy. And this is a potentially very powerful technique. If we can start to detect tumor cells that might be circulating in the blood, not only is it a way for us to determine whether it's an early detection biomarker, but we can also profile these cells genetically and use that as a way, for example, to know what genetic mutations exist in a patient's tumor and whether those genetic mutations predict things like metastases and whether those genetic mutations might be useful for tailoring specific kinds of treatment. And so this is a trial that we've actually started at MGH, where we're actually trying to do more of this circulating tumor cell isolation among patients with gastric cancer. We're taking, at this point, some whole blood from patients and actually doing a pheresis procedure to actually concentrate the blood and concentrate the cells that we collect, putting these cells on these magnetic beads and separating tumor cells out from the rest of the cells that you find in normal blood. And this is, again, allowing us an opportunity to detect different molecular changes in the cells that gives us some insight into the biology of the tumor, and also is a way for us to determine that we have tumor cells as opposed to other types of cells in the bloodstream. And then the last area I want to talk about is novel imaging. So many of you know that white light endoscopy has still been sort of the go-to test that we have to detect gastric cancer in patients who are presenting with clinical symptoms in the US. And then in Asia, endoscopy is being used more and more for screening overall. But endoscopy does have its limitations, and that's because we use a white light to look in the stomach, and sometimes we just don't see gastric cancers very well. They can be very hard to look at and very hard to see endoscopically. And so many gastric cancers are actually missed on a traditional white light endoscopy. It's much less sensitive in picking up gastric cancer than, for example, a colonoscopy is in picking up colon cancer. So we really felt there was a need to improve our ability to more sensitively detect areas of precancer and gastric cancer in the stomach, which is why we started to develop a novel imaging platform to actually detect molecular changes that we might expect to be found in precancers. So in particular, let me take you through what this involves. It involves actually a novel molecular imaging agent known as LUM-15. And LUM-15 is a molecular imaging agent that was developed by a company in Massachusetts called Lumicell that we've partnered with. And Lumicell developed this initially as a way to detect tumor cells in patients with breast cancer. And in particular, patients with breast cancer who are, for example, having a lumpectomy. The concern when you do a lumpectomy is that there might be some residual tumor at the margin. So they've developed this molecular imaging agent to inject into patients and have people have this particular imaging agent hone in on areas of cancer at the margins of these breast cancer surgeries. And so you can determine whether you've adequately resected the breast cancer from a patient who's having breast cancer surgery. So understanding that theory, we were really interested in potentially using this for endoscopy. If we can use a molecular imaging agent to actually hone in on areas in the stomach that we believe are precancerous and have those areas light up, that could be a very sensitive way to improve white light endoscopy. And how that works is basically tumors in general have overexpression of an enzyme known as cathepsins. These are proteases or specific enzymes that are known to be expressed in cancer, and these enzymes also break apart certain bonds in some of our molecules. So what we do is we inject this LUM-15 molecule into the patient, and if it circulates into the blood, goes into the stomach, and goes into areas of tumor, and the tumor cathepsins actually cleave a fluorophore, or a molecular beacon on the protein that allows it to emit a fluorescent light that can then be picked up through an infrared endoscope. And this is an example of the image that we have produced in a patient with gastric cancer in our lab. And you can see that there are areas that are that light up compared to regular tissue, and those areas are areas that we think overexpress cathepsins and are more likely to be precancerous. And so this has been very exciting work that we're hoping to develop into a large-scale clinical trial that we are supported by Stand Up to Cancer to do, as well as with support from Lumicell in the next year. So we're looking forward to not only moving the needle on blood-based detection, but also in endoscopic imaging. And you can imagine that this was a very powerful way to monitor for recurrence in patients with gastric cancer. So after someone, for example, has had a partial gastrectomy for gastric cancer, if you can give them a molecular imaging agent, and that hones in the area of the stomach that's more likely to be precancerous or cancerous, you can then know earlier that someone has had a recurrence, and also potentially find an area of the stomach that could be cured through curative resection. So it has a definite benefit for not only early detection of gastric cancer, but also therapeutic monitoring. And I would say the potential hope is that this will be particularly useful in patients with diffuse type gastric cancer, which, as I explained, is very, very difficult to diagnose because those lesions are very, very subtle and very difficult to see on white light endoscopy. And currently, our approach to those patients is to just randomly biopsy the stomach and hope that we find an area of cancer. And you can imagine that requires a lot of biopsies for one, and a lot of luck. And if you happen to hit upon an area that has cancer or precancer, then that patient is fortunate to have been diagnosed. But if you don't happen to sample that area, a precancer can still stay in a patient undetected and eventually grow into a cancer over months to years. And so the ability to potentially affect the early diagnosis and detection of cancer in the setting of diffuse type gastric cancer is particularly important, and one that I think this potential technology may really make a difference for. So what are the key takeaways? Well, I hope I've convinced you, and I think all of you are quite aware that early interception is the key to reduce mortality from gastric cancer. So when patients are diagnosed at stage 1, stage 2, their prognosis is much, much better than when they're diagnosed at stage 3 or stage 4. And we all know that the type of treatments and the morbidity and mortality of being diagnosed at late stage is also a real reason for why we need to try to move the needle on diagnosing patients earlier. The most promising areas that I think are out there now for early detection and interception is blood-based biomarkers. I mentioned the ORF1P protein, and you'll hear more about that later in a few days, and also the detection of circulating tumor cells. And that's a really promising approach that we will potentially be able to introduce to patients in the near future. Molecular imaging, I think, does also have a lot of promise, and particularly can improve endoscopic detection of early cancer in high-risk populations, for example, patients with the CDH1 mutation. And we have clinical trials that are soon to be launched. We were really happy to hear that Stand Up to Cancer originally funded our team for a 3-year grant period, and we were fortunate to get an extension of that grant funding, so we now have another 3 years to really work on this project. And we're grateful, of course, for their support, but also the support of the gastric cancer community in our research, because I think it's their advocacy that really has motivated groups like Stand Up to Cancer to fund the research. And so all the things that you guys are doing on Capitol Hill is so critical and so important for us to advance this work. And I just would mention, just as on a personal note, I don't know if many of you follow the news, but there's been a recent effort, or there has been a policy that's just been put in place by the federal government to decrease the amount of funding to major hospitals and universities to support research. So at this point in time, medical research in our universities and hospitals is very vulnerable, and all the progress we've made over the last several decades is under threat. And so I really admire and appreciate all of your efforts on our behalf. And so when you go to Capitol Hill on Monday, these cuts to the NIH, and in particular, the specific policy that was put forth was that they were going to cut what they call the indirect cost rate to universities from 50, 60% to 15%. So drastic cuts that will really lead to the inability for a lot of us to be able to continue our work. And so although we are very hopeful for the future of the science, that really requires resources and support from the federal government as well as foundations. And obviously, that is a message that I think all of us can try to share with the people that represent us in Congress. So with that, I'm very, again, honored to be here and to be able to interact and meet with all of you, and also to give us a chance to share with you our research. And hopefully, we'll be able to get a chance to really lead this the whole way into clinical trials, so we can really start to find ways to help patients get diagnosed earlier, and to help patients who are diagnosed with gastric cancer be monitored more closely for recurrence. And with that, I'm very happy to take questions.
I have it up.
Testing.
Oh, okay, cool. Question for you. I have NTRK, gene mutated adenocarcinoma. And I know I'm on right now a clinical trial for this particular cancer. It's called Vitracavy. They discovered it in Germany in 2018. Have you heard of it? And if you have, what have you heard for the cure for this particular cancer?
Yeah, I have heard of it, and I have had some interaction with patients that have been, interested in getting that therapy or on that therapy. But unfortunately, I'm not a oncologist, so I wouldn't be able to comment specifically about the therapeutic efficacy of this particular drug or this particular situation. But I think what you're speaking to, I think, is an example of where increasingly in the therapeutic world, we are using molecular profiling of our cancers to guide our treatment. And so I think that does have relevance to also the kinds of methods that we're trying to deploy for early detection and monitoring. For example, if we're able to detect circulating tumor cells and profile those tumor cells mutationally, that can give us some leads onto the kinds of therapies we should be, deploying for our patients, particularly in settings where maybe we're not able to get, a good molecular profile from the cancer tissue.
Okay, so for those of you who do have it, have never heard of it, Bayer Pharmaceuticals is actually backing the research for NTRK gene-mutated adenocarcinoma, and because of the clinical trials, they are using people like us, where they do take my blood, my biomarkers worldwide, and they are looking for that particular cure for this cancer. So I don't know if anybody else who has this, but I'm super excited, and I was just hoping that there would be a cure at some point so I can stop taking this research drug. And I'm less than 6%. Oh, Circulogene Thermologistics. That's the research company that is working on it, Circulogene. So they come every 3 months. They take my blood, and they are actively looking for this cure. So I'm hoping and praying it all comes soon.
Yeah, thank you for sharing that.
Hi. So my question, as you're talking about circulating tumor cells and monitoring, do you know much about Signatera, or is there a more specific test that we should be asking for? So like very similar to what she's going through. I have Signatera being taken every 3 months to monitor. What do you think? I guess what is your opinion on?
Yeah, so there are various other commercial tests that are currently being used to for both early detection and monitoring that are around largely detecting DNA, either DNA fragments or DNA mutational profiles. So I think that is in particular for therapeutic monitoring, that's a very promising area. Which I think will hopefully be useful in many different types of cancer, not just gastric cancer. So I think that is definitely something that has a lot of promise. Whether those things can actually be used for early detection, I think remains to be seen, because it requires a fair amount of blood and it requires a fair amount of circulating DNA to be detectable. And that's often not the case in sort of early stage gastric cancer or for screening purposes. So it's not yet really been fully utilized and really been shown to be promising for early detection. But there are other companies that are working on other types of early detection blood-based biomarkers. Many of you have heard, for example, of GRAIL or Guardant. So those are companies that are also in this sort of blood-based biomarker space. Guardant actually has a blood-based test that's been FDA approved for colon cancer, and they're working on a multi-cancer detection blood-based biomarker as well, but it's not specific for gastric cancer. I don't think there are any companies that are doing one specific for gastric cancer yet.
Quick question. I'm in the back here.
Yes.
You showed really dramatic, very clean margins on your imaging. Like it's there and it's not there. Mm-hmm. I was puzzled by why you said it would be better for, or something good for, diffuse adenocarcinoma. It seems like the opposite to me. Like it would be harder to see and associated with kind of a high false positive rate or false negative rate.
No, I do think diffuse will be more challenging. So I do think that it's going to be more challenging to be able to detect diffuse type gastric cancer, even with molecular imaging approaches, but I think it will be a step up from traditional white light endoscopy. But I do think it'll be more challenging than intestinal type. I think intestinal type is still probably going to be easier.
Okay. Thank you so much. Both Dr. Chan will be at dinner, and Irasema is coming up.
Thank you so much, Dr. Chan. We are so grateful for your presentation. Our next speaker is Joanna Fawzy Doran, CEO of Triage Cancer. Joanna is a cancer rights attorney, author, speaker, and CEO of Triage Cancer, a national nonprofit organization providing free education on practical and legal issues that may impact individuals coping with cancer and their caregivers through events, materials, resources. Ms. Doran has spent nearly 30 years working on behalf of individuals with cancer, including 5 as an adjunct professor of law at Loyola Law School, teaching a seminar in cancer rights law, and 8 at the John Wayne Cancer Institute's Psychosocial Care Program and Positive Appearance Center. Please, let's welcome Joanna.
Good evening, everyone. No problem. I will stall. Thank you for having me here tonight, but I also want to thank you all for being here. Advocacy is very important to me, and so I really appreciate that you are taking the time to learn and to also use your voice. When I tell people I'm a cancer rights attorney, I always get kind of a funny look. People inevitably ask me what's legal about cancer, and I tell them almost everything. So whether or not there is funding for research is a legal issue. Whether or not the Food and Drug Administration approves a particular treatment is a legal issue. Whether or not insurance pays for that treatment is a legal issue. Whether or not you get to take time off work to get access to that treatment and not lose your job is a legal issue. So it's just things that we don't necessarily think of as legal issues, but there are laws and protections and benefits and programs that are actually all rooted in the law. And that's what we do at Triage Cancer. We teach people about the law and how to tap into those benefits and protections and resources. Where are we at? Are we good with the slides? Okay. So at Triage Cancer, we provide that education through events and resources and materials. And many of those legal issues are actually also contributors to financial toxicity. So the cost of care, how insurance is covering that care, if you have to take time off work, how do you replace lost wages? All of those things can actually be contributors to financial toxicity. And the number one thing that we think at Triage Cancer is the greatest contributor to financial toxicity is having adequate health insurance coverage. So certainly having insurance is helpful, but having adequate health insurance coverage is key. And then you also have to know how to use insurance. And in the United States, we don't know how to do that. We don't understand our healthcare system. And it used to just be my anecdotal opinion based on the experience of working in the cancer community that led me to that conclusion. But now there's data to back it up. So 96% of Americans don't know the 4 key terms used in health insurance coverage. So if we don't know the words, how are we supposed to be educated consumers to make decisions that give us adequate health insurance coverage? And then how do we actually use it? So it's not surprising that only 40% of people could actually feel confident in picking a health insurance plan for them. But I would argue they're probably overconfident if they don't know the words, right? So we are constantly in a situation where, as consumers, we have more and more information. And that doesn't apply to health insurance. So we can buy anything online now, but buying health insurance is a challenge because we don't actually understand how it works. Just checking in. Okay. You're really testing my memory. So when we talk about health insurance and those 4 key terms used in health insurance, we pay a premium, a monthly premium, just to have health insurance coverage. So even if we got no medical care during the year, we would still pay our monthly premium, a fixed dollar amount each month. But then there are costs that we pay when we actually use our health insurance and we get medical care. And the first is our annual deductible. It is a fixed dollar amount that we have to pay first before our health insurance coverage even kicks in. But then there's something called a copayment, and that's a fixed dollar amount that we have to pay when we get certain types of care. So you might have a $10 copayment to visit a primary care physician. You might have a $50 copayment to see a specialist. You might have a $500 copayment if you have to go to the emergency room. That's different from coinsurance or cost share. So those are two terms that are used the same way. It's a percentage. It's the difference between what insurance companies pay for our medical expenses and what we pay for our medical expenses. So if we have an 80-20 plan, insurance is going to pay 80% and we're responsible for 20%. The most important thing that anybody should know about their health insurance policy is their out-of-pocket maximum. Because in a worst-case scenario, that's the most that you're going to pay out-of-pocket for your medical care during the year. The out-of-pocket maximum is a fixed dollar amount, so you have a $1,000 out-of-pocket maximum, or you have a $15,000 out-of-pocket maximum. The amounts are going to depend on the plan that you have. So how you get to your out-of-pocket maximum is actually a math problem. So you get to add up what you pay for your deductible, plus any co-payments that you make, plus any co-insurance amounts that you pay during the year, and that helps you reach your out-of-pocket maximum. And when you do, then your insurance kicks in at 100% for the rest of the year. So it lets you plan around that worst case scenario. So I hear physicians tell me a lot, well, I don't know what treatment is going to cost my patient, because you can't predict, right, what all that treatment might entail. But you do know the out-of-pocket maximum. Thank you. The out-of-pocket maximum is the most that you're going to pay throughout the year. So now, excuse me while I flip through this really quickly. So I have lots of tips around avoiding financial toxicity, which is what I was asked to talk about today, but I'm going to give you 6 key ones. I've already told you all of this already. All right, so let's look at Dan to see how that out-of-pocket maximum works. So he has a plan that's a $2,000 deductible. It's an 80-20 plan, and he has an $8,000 out-of-pocket maximum. He gets into an accident. He spends a week in the hospital. He walks out with a $102,000 hospital bill. Assuming he's had no other medical expenses during the year, what does Dan actually have to pay for that bill? Any ideas? It's $8,000 because that's his out-of-pocket maximum, but this is how you get there. So first he has to pay his $2,000 deductible, which leaves $100,000 left of that bill. And he has an 80-20 plan, so the insurance is going to pay 80%, and he's responsible for 20%, which is $20,000. But how much does he actually have to pay of that $20,000 bill? $6,000. Because he has the $8,000 out-of-pocket maximum, and he's already paid his $2,000 towards his deductible, so he has to spend another $6,000 to get to his out-of-pocket maximum. Now, I'm not suggesting that $8,000 isn't a lot of money, but at least it's not the $20,000 bill that he would have to pay for his coinsurance. So it provides that cap. So when we talk about the law, the devil is always in the details. That is generally how an out-of-pocket maximum works, but it depends on the type of plan that you have. So if you have a family plan, you'll have an individual out-of-pocket maximum and a family out-of-pocket maximum. If you have a marketplace plan, that's actually the most protective for consumers because it includes copays, deductibles, coinsurance for both medical care and prescription drugs. Employer plans are allowed to carve things out. So they might say, we're not going to let your deductible contribute to your out-of-pocket maximum, so you have to pay both. Or they might say, we're going to give you a separate out-of-pocket maximum for your prescription drugs, so you have to meet both of those. So you have to know how your out-of-pocket maximum works specifically for your plan. So my first tip is that you actually have to know all of your health insurance options. We tend to learn about one option. So if we have an employer plan, we look at the employer plan and we don't really think about what else might be available to us. And I'm not going to spend time tonight talking about all the various health insurance options that exist. I could take hours to do that, but I do want to point out that we have a lot of resources at Triage Cancer to help you understand health insurance options, because you can't make a good choice about what's best for you until you know what all of those options actually are. The second thing is that you have to know how to pick a plan that can actually lower your out-of-pocket costs. I said the number one contributor to financial toxicity is having inadequate health insurance. So how do you actually make sure you have adequate insurance? And I'm going to walk you through an exercise that is useful if you're comparing marketplace plans. If you get multiple options from your employer, you can compare them. You can compare what your employer offers to an individual plan, or you can compare Medicare Advantage plans using this same exercise. So here we have 3 plans. There's a bronze plan at $200 a month with an $8,000 out-of-pocket maximum, a silver plan at $275 a month with a $6,000 out-of-pocket maximum, and a platinum plan at $400 a month with a $2,000 out-of-pocket maximum. Can you tell, just by looking at these plans, which is actually going to cost you the least by the end of the year? Assuming that you're going to hit your out-of-pocket maximum, because the likelihood of that is pretty high. No, you cannot tell just by looking at them. You actually have to do the math. The way that you do the math is that you take the monthly premium and you multiply it by 12, because that's how much it would cost you to have the plan for the year. And then you add that to the out-of-pocket maximum, because that's the most that you're going to pay out of pocket for the year. So it turns out, in this particular example, that the platinum plan actually ends up saving you a couple $1,000s by the end of the year, even though we get sticker shock when we look at the monthly premium in comparison to the bronze plan. But unfortunately, because most people don't know what an out-of-pocket maximum is, they only shop for insurance by looking at the monthly premium. And that is where it can be a very inadequate plan in terms of the out-of-pocket costs that you might have to pay. Now, this math is never the same. It's going to depend on whatever plans you have available to you and doing the math for those options. But it isn't just cost that you have to be looking at. You also have to make sure that you're picking plans that actually cover your providers and your prescription drugs. Because if you pick a plan that doesn't cover those things, you're going to pay more out of pocket to see those out-of-network providers or for those drugs that aren't covered by your plan. So there are some other things to take into consideration. We have a lot of tools to help you do that. We actually have an animated video that is 5 minutes long that explains what I just did. So if you want to see it again, you can see it. But we also have a worksheet to help you do that math comparison. So it's our health insurance comparison worksheet. And we have that for private insurance, but we also have it for Medicare, because the same types of math and assessment applies in Medicare as well. But then there might be other ways to lower costs related to buying insurance. And I just want to give you a couple of examples. If someone is leaving their job or loses their job or even reduces their hours at work, they might lose access to their health insurance coverage through their employer. And COBRA is the federal law that allows you to keep access to that employer plan. But you're paying 100% of what the employer was paying for your plan. And that can be very, very expensive. But there is a program called the Health Insurance Premium Payment Program. And it's actually a state-based program through Medicaid where if you qualify for Medicaid in your state, Medicaid will actually pay your COBRA premiums for you because it's less expensive for the state to do that than to pay for all of your care under the state Medicaid program. So they actually do the math to see which is better for the state. But it is a way for you to keep access to your COBRA plan and have them pay for it. When we're talking about the marketplace, there are some benefits to buying coverage through the marketplace, including consumer protections that I mentioned, but there's also financial assistance based on your income level. And this is what it looks like based on income level. If you have a household income between 138 and 400% of the federal poverty level, you actually can qualify for financial assistance to lower your monthly premiums for any plan you pick in the marketplace. But because of some COVID-related laws, there was additional financial assistance added to the marketplace. And now 4 out of 5 people can actually find a marketplace plan for $10 or less per month, which is almost, I can't believe I say that. When I say that, it's like hard to believe that you could buy health insurance for $10 or less per month, but it actually is true. There is also additional financial assistance for people who have a household income over 400% of the federal poverty level, because if it costs you more than 8.5% of your household income to actually buy the plan, they lower your monthly premium so that it doesn't cost you more than 8.5% of your household income. But this financial assistance is time limited. It will end December 31st of this year unless Congress does something to extend the financial assistance. So, advocacy. When it comes to Medicare, there are actually two different types of programs to help with the costs of Medicare. There are a whole series of programs called Medicare Savings Programs, which, depending on your income level and your assets, those programs will help pick up the out-of-pocket costs related to Medicare and some of the premiums. And they're kind of funny names, QIMBY and SLIMBY, but we actually have a quick guide that explains all the programs and how to qualify for them. And then there's a separate program called the Low Income Subsidy, or the Extra Help Program, which is also based on income level, that picks up out-of-pocket costs for prescription drugs in Medicare. I do want to just mention, for anyone who is on Medicare, this year, as a result of the Inflation Reduction Act, there is a $2,000 out-of-pocket maximum on prescription drugs, which is historic coming for the Medicare program in terms of capping out-of-pocket costs for drugs. And they created a payment plan where if your drug costs hit $2,000 earlier in the year, you can actually spread out those costs in a payment plan to spread them out over the year. So you can pay monthly towards those costs. So they not only capped the out-of-pocket costs, but they made it a little bit easier for us to practically pay those costs. Now, I mentioned getting health insurance is only step one. You actually have to know how to use that insurance effectively. And I want to give you an example of that. It is not uncommon for an insurance company to deny coverage for care. That could be a prescription drug, a treatment, a surgery. It is actually pretty common for an insurance company to deny coverage. There is the opportunity to appeal that decision and not take no for an answer. And when we're talking about private insurance specifically, so individual and employer plans, there are two levels of appeal. There's the internal appeals process where you go back to the insurance company and say, I'd like you to reconsider. If they still come back and say denied, you now can go outside the insurance company to an independent entity, and they look at your situation and decide whether or not it's medically necessary for you to get access to that care. And if they decide that it is, that's binding on the insurance company. That process is called the external appeal or independent medical review. This is actually our best kept secret of our healthcare system. No one knows about it. And when I say no one, I actually mean no one. I mean patients, I mean providers. This is data specifically from Marketplace Plans for 2001. There were, I know you can't read it, but there are about 48 million claims denied just for these plans in that 1 year. 99.9% of those claims that were denied were not appealed, even to the first level of appeal. 99.9% of people are taking no for an answer, which on a practical level is super concerning because that means patients aren't getting access to the care prescribed by their healthcare team, or they're paying for it out of pocket. So this by itself not only contributes to lack of access to care, but it also contributes to financial toxicity because patients are paying for care when insurance companies should have covered that care. And what I didn't tell you is that when someone gets to the external appeal stage, on average, about 50% of the time, they're successful. So when you think about 48 million claims, that's 48 million people who didn't get access to the care or paid for it out of pocket, but about 50% of them would have been successful in an external appeal. So we have a lot of resources to help people navigate the appeals process, but it does depend on the type of plan that you have and type of insurance. There are different steps to the processes, so we have resources to help you figure that out. Now, when it comes to insurance, even if you have the best health insurance and it's very adequate, you're still going to have medical bills. The problem with medical bills is that it generates a lot of paper, and that could be physical paper, or it might be emails or notifications in your online portal, but it generates a lot of things that you have to read. And so from an insurance company, you might get a letter saying, we've received a claim from your provider. You don't have to do anything with that claim, but we've received it. Then you might get a letter that says, now we're processing that claim. Still don't have to do anything with that, but then eventually you'll get an explanation of benefits, and it looks something like this. A good explanation of benefits might even have words on it as opposed to just codes. But this chart-looking explanation of benefits is really important because it tells you how your insurance company handled that claim from your provider. The last piece of information you're going to get is the bill from the provider. The problem is that those pieces of paper do not necessarily arrive in chronological order. So you might get the bill first before you get the explanation of benefits. And it's very important that you actually wait for the explanation of benefits before paying that bill, because you want to make sure those two pieces of paper actually match up. You want to know that your insurance company actually paid what they were supposed to pay for the bill and what your responsibility is left. You want to make sure that there was nothing that was denied. And in that case, if you do, you want to actually appeal that denial. So you need to make sure that those two things actually match up and that there weren't any mistakes before you know what you actually have to pay to the provider. I do just want to mention there is also a really fantastic organization called $4, and they help patients figure out if they qualify for the financial assistance programs available at their hospitals. So nonprofit hospitals in the United States are required to provide something called charity care. It might be called something different at your hospital, but basically they have to provide a financial assistance program based on income levels. But they get to decide the rules, and trying to find that information can sometimes be hard. $4 will do the work for you. Even if you have old medical bills, you can go to them and say, should my hospital have given me financial assistance, and help negotiate with the hospital to get that help. So they're a fantastic organization that does all of that for free. If you're in a situation where you feel like you can't pay that bill, you can actually negotiate a payment plan with most providers, but you have to ask for it. They often aren't going to volunteer that information up front. You could potentially even ask for them to write off a portion of the bill. Sometimes they'll accept a lump sum payment instead of setting up a payment plan, because they'd rather have some money now than to set up a payment plan over a period of time. So you could potentially negotiate with them for that lump sum payment as well. Keeping track of your medical bills can be useful for a couple of reasons. We actually have a medical bill tracker on our website that you can download. And what is useful about this is that you can actually put in your plan information, so your deductible amount and your out-of-pocket maximum. And then as you add in information about each of the bills that you pay, it will calculate for you the total that you have to continue to pay to meet your deductible or your out-of-pocket maximum. And some insurance companies now will keep track of that for you. They'll even put it on the EOB. But it's always a good idea to make sure what you're actually paying matches up with what they think you're paying, and that you have reached your out-of-pocket maximum so that you don't have to pay any more throughout the year. It can also be very helpful to keep track of what you've paid, because that actually might be tax deductible. So keeping track of the expenses can help you at tax time find out if you could actually get some money back from taxes or lower what you have to pay in taxes. So my fifth tip is that you want to know how to think as creatively as possible about financial assistance. So if you need help paying those medical bills after you've figured out what you actually owe, there are lots of resources out there to help with financial assistance, but sometimes you want to think as broadly as possible. So maybe you don't qualify for a program that pays for medical bills. but maybe you qualify for utility assistance in the community where you live. So you could get help with your utility bills there and use that money to help pay medical bills. And so sometimes people kind of think too narrowly when thinking about financial assistance that's available. So we have a lot of resources on our Cancer Finances Toolkit in 2 places. So we have a financial assistance module, which has different types of resources by category. And then we also have a module on prescription drugs and managing the costs. And in this module, in addition to information about programs available, we also have this chart that lists all the drugs in the cancer community and the companies that make those drugs and the links to the financial assistance programs from those pharmaceutical companies. So we've done the Googling work for you and compiled all that information in this chart. And then my last tip is to know where to go for help and more information. And at Triage Cancer, we have a lot of resources to help you navigate these topics. So there are print materials, there are animated videos, we have a podcast, but we also host free educational events. We have our monthly webinar series that covers a variety of different topics. This feels a little late for you all because you're here this week to engage in advocacy, but later this month we have a webinar on how to engage in advocacy in the cancer community. But then we have topics that cover the gamut throughout the rest of the year, and if you miss a live webinar, you can watch past ones on the website. We also have our Triage Cancer Conference, which is a full day that talks in much more detail about the things that I've shared with you today, as well as topics around getting organized, unemployment and disability insurance, and finances and strategies for planning ahead. So those are free one-day events as well. And then if you still have questions about your individual situation and want to get answers, you can actually contact our legal and financial navigation program. So if you go to our website at triagecancer.org/gethelp, you can sign up for an appointment to talk with our team to get answers to your individual questions. So with that, I will ask if there are any questions tonight.
Perfect. Thank you so much, Joanna.
Yeah, I had a question regarding prescription medications. For those prescription medications that insurance doesn't cover, if we actually pay out of pocket for them, I mean, smaller amounts, right? $20, $30 a year or whatever. Those won't count towards the maximum out of pocket or the deductible or anything else, right?
That's a great question. So if you are taking a drug that is not covered by insurance, what you pay out of pocket for that drug doesn't go towards your out-of-pocket maximum. So they will only include things that you're paying for if they're in-network providers or things that were on the formulary. But I do want to mention, it is very common for insurance companies to not have a particular drug on their formulary, which is the list of drugs covered by a particular plan. It doesn't necessarily mean that they won't need to cover it. So if it's a drug that you've been prescribed that is not on the formulary, you can ask for what's called an exception request. So you're asking for an exception to the formulary to get access to that drug, but you really have to work with your healthcare team to describe why is it medically necessary for you to get access to that particular drug. So they're really great allies in getting access to the medications that you need if you're in a situation where your insurance company is saying no. So, and lots of healthcare teams do this for you anyway, and you might not even know it's happening because they're doing that for you behind the scenes. But if you end up getting the denial letter from an insurance company, it's very important to go back to your healthcare team and ask, if it's important for me to get this particular drug, can you help me with that exception request process? And if the exception request is denied, you can actually use the appeals process that I was talking about to get access to the drug as well.
Thank you.
They're coming with the microphone.
I'm coming.
Hi, so I know you mentioned the option that you said was like the best kept secret. Is that similar to a peer-to-peer review?
That is such a good question. I'm so glad you asked. It is absolutely not. So the peer-to-peer review process is when an insurance company has a doctor or a healthcare professional employed by the insurance company who talks to your healthcare professional. And you would think that having, two people having a conversation about what's appropriate for a patient would be really practical, but that often still results in a denial. That is all in the internal appeals process. So you're still talking to the insurance company. And they often kind of make it sound like the peer-to-peer review is an external review, and it's not. It's still internal. So even if the peer review is denied, you still get to go to external review.
How would you go about, going down that route?
So the first step, kind of generally, depending on the state that you're in, is to start with your state Department of Insurance. And to make it easier, we have this information on our website. On our state resources page, you can scroll down to the health insurance section, and it has the agency in your state that handles this. And then we have step-by-step instructions. But you can always start with your state insurance agency to ask, what's my state-specific process based on the type of plan that I have for getting the access to the external review process.
Oh, thank you.
Of course. Good questions.
Is it hard after you have a diagnosis of something like stomach cancer to then change plans for a plan that may be better for you?
As a result of the Affordable Care Act, there is protections against denials for people with pre-existing conditions, and they can't charge you more because of those pre-existing conditions. But I will say that that is as a result of the Affordable Care Act. So again, it's because of advocacy that we have those protections.
You mentioned that some utility providers provide discounts for cancer patients. How would a cancer patient go about? Do they have to contact their local?
Yes. So there are different programs. So you can always go directly to your utility provider and find out what their specific programs are. There's no requirement that they provide those programs. So it's specific to the provider. And it's usually based on income level, not necessarily based on somebody's medical condition, but you can contact the provider to say, do you have an assistance program? There are also some federal programs. So there's the LIHEAP program that helps with energy. So heating and cooling. There's a water program. There are programs for phone and internet coverage, which actually the enrollment has been capped because Congress has not extended funding for that program. So there are lots of different programs, and you can find actually all of that on our Cancer Finances Toolkit.
Okay.
Thank you.
Thank you, Joanna. We are so grateful for your knowledge that you shared with us this evening. Okay, so with that, we are now breaking for dinner. Dinner will be held in the next room, and then we will be back at 8 p.m. For Malignant Comedy Session with Jamie Becker and Stephanie Klein. Thank you so much, guys.